Welcome to the Syneos Health Podcast, Conversations on Commercialization. I'm Tyler Cowan, Vice President Commercial at Syneos Health. In this series, my co-hosts and I are having discussions on how biopharma leaders are rewriting the commercial playbook and what it takes to succeed as commercialization takes on a more strategic role earlier in product lifecycle. We're sharing cross-functional perspectives on the decisions shaping commercialization today, from value and access to evidence, stakeholder strategy, and engagement planning. Enjoy this episode. We're glad you're here.
Hi, I'm Kim Plesnarski from Syneos Health, and I'm your host for this episode of the Syneos Health Podcast, Conversation on Commercialization. We're recording from the floor of Asembia 2026, where the industry gathers to discuss the future of specialty pharmacy, prescription access, and patient care. Today, I'm joined by my two guests, Brian Seamack, VP of Portfolio Strategy, Mankind. He's responsible to ensure his organization is placing the right bets today for tomorrow. And Terry Melton, AVP, Field Reimbursement at Eli Lilly, where he is focused on rethinking what it means to have a pull-through team and strategy in a rapidly changing market where payers and patients have more control than ever. I want to thank them for joining me. We just finished an amazing panel conversation on the floor. I learned a lot through the process. I'm hoping the audience learns a lot through our conversation. We want it to be thought-provoking. We want to acknowledge we're all facing unprecedented change, uncertainty, and pressure. We're being asked to rethink how we deliver in field reimbursement and patient support, and we all truly believe what we've done in the past to be successful is not what's going to get us there in the future. We want to land on a few things that are going on in the market. There is tremendous pressure on gross to net. Patients and providers are demanding more control. We're seeing new distribution models evolve, and we're seeing a rapid pace of technology and a lot of pressure to launch that new technology, including AI, the buzzword. So we're going to touch on how do we do it, what's best practices, and how are we going to redo the commercial model. It is broken, and we need to figure out how do we move beyond cost and scale to be more efficient. So I'm going to start with Terry. Where are you feeling the most pressure today? Is it access, cost, or execution?
Well, first of all, thanks for having me. I appreciate it. Had a really good time today on the floor doing our earlier topic discussion. The pressure felt today is actually everywhere. It is across all those avenues. And you touched on the gross to net. I think one of the things I actually want to try and bring to life here is this gross to net conversation for a hot second, because gross to net has to take into account all things from OPEX, shared services, service agreements, rebates. And when you start backing all of that out, your true gross to net is left very low. And if you do SP contracts and you do access contracts, rebate contracts, you build a customer support program, all those fees have to come out of that gross to net. So that's why we're trying to focus in on how we maximize and become really efficient as you think about the gross to net.
I love that. Brian?
I echo Terry's sentiments for the panel and the discussion. Terry hit on a great point. There's the official gross to net, which has your copay, Medicaid discounts, all that stuff. But the real cost is like if you put your hub, your navigator teams, your FRMs, if you do all that, you're really not left with much profit. So I think that's an important distinction. I look at it not just as market access, but it's the whole journey from getting payer coverage to getting a patient on therapy to fulfillment. In my role, that's our biggest challenge right now. I mean, awareness, obviously, but also getting that access to patients. So we're trying to focus our strategies and our tactics to facilitate that.
So what I'm hearing is pressure isn't isolated, it's everywhere, and it's compounding. But let's start with Brian. What's changed the most in the last 2 to 3 years that you believe the commercial model hasn't quite caught up with?
I think you used to have, you go to your doctor, get a script, it was covered. It's never simple, but it was easier. I think today, there's just a lot of pressure on that system. One, I think would say is the vertical to horizontal integration of both HCP practices and payers. Payers kind of owning the chain from SPs, PBMs, and all being one that they're more power to get the terms that they want. We're all trying to get on formulary, and that's difficult. I'd also say the direct-to-consumer model, it's changed a lot. The way people consume healthcare has changed, and the old model works, but now people, especially in certain disease states, can go through their computer and get on therapy by have a telehealth consultation, which is new, and I think you need to build your solutions to take all of that into account.
I agree with you, Brian. I think it's funny. I tried to touch on this earlier a bit, and I don't think did a good enough job, but The tools that are out there now in the healthcare environment are different. It makes it really complex. So like you think about payers using accumulators and maximizer programs, and you think about third-party payers as well, or third-party agreements with associates. But you have people coming in that are going to help you save the day, but yet they're going to take a chunk of your cost as well. And then as a consumer, you're told your out-of-pocket is X, but yet when you get to the pharmacy, it's actually totally different because of the influx of these types of what I call artificial barriers from an access perspective.
I'd like to add one. Terry brought up a good point. I think one of the other changes is the shift to consumers paying more for their health care.
Yes.
You used to just pay your twice monthly paycheck and it'd be a small copay. But now the burden's shifted to the consumer and they have choices and they have to make real choices because budget isn't infinite. So that dictates what care they ultimately get. That's a challenge that as an industry we need to help fix.
I couldn't agree more. I'm going to ask a follow-up question that you guys started touching on, which is technology. If you're at Asembia right now, almost every booth is AI or new tech that's coming out. It's overwhelming. It was a similar theme last year. When you're thinking about new technology and the programs you guys are running are thinking about, what has been the biggest learning so far?
For me, the biggest learning is that AI is not going to replace my team. I don't think I'm unique in that, by the way, but I think there's a healthy fear that AI is going to come in and it's going to take away jobs. This reimbursement area is so complex that AI needs to be looked at as a utilization tool, an efficiency play to help my team get smarter, move quicker, to help more patients. It's not going to take over, but it's definitely going to help a lot.
I agree with Terry. I think we're not going to be replaced by robots. It is a force multiplier, though, right? I think it allows your team to be more efficient and work more cases. And there's certain tasks like benefits verification that you don't need a human to do, and they can work more cases and do more impactful work. For technology perspective, like how we use it, I always think, does it make patients and HCP's life easier? If not, it's not worth investing in. Thinking of the end user experience is really important. There's so much technology and a lot of it's very, very cool stuff, but it doesn't fit the use case. So why would you use it? And separating the noise, I think that's the most challenging part that people like Terry and myself have, trying to pick the right technology partners and technology for these programs.
It's efficiency, it's picking the things that reduce work, not add work. And I would say the last piece that I'm really seeing is around the adoption. The learning I'm seeing is people are underestimating the amount of lift it takes to change behavior, get individuals, whether it's a patient, an HCP, or the program team, to adopt it. And lastly, to make sure it works and keeps working. What maybe keeps me up at night is how are we evolving our framework, our working governance to address that, to help people get there. All right, so Terry, talking about how we're rethinking things. Normally when a manufacturer is thinking about using a partner, they focus on capabilities. Are we solving the wrong problem by focusing on capabilities instead of the strategy and the design?
If we don't design it right, then the capability doesn't really matter. And I think one of the things that I've grown to appreciate with my partnerships is when I have a partner that's going to help me actually whiteboard and think through what the design really needs to be. So I have a problem, 100% I have a problem, but now I need a partner to help me figure out how to solution for it. And we have to spend more time on design, and then we can come back to capabilities.
Brian, anything you want to add there?
Thinking about the outcomes that you want first, start there and work backwards to the design. I think having a partner that is a true partner and helps with strategy. I've been part of service providers, I've used service providers. A lot of time, you're sold capabilities and they're just like, we're here to do X or Y. And you're like, that's not helpful. Be a strategic partner, help us think through it. You guys have the experience running multiple programs. I have my worldview, but that's based on where I work. But a company like Syneos working at 20 some odd patient service programs, probably a lot of great learnings that could be applied to our experience. We welcome that kind of consultative, collaborative, strategic, whatever you want to call it, partnership.
Okay, so you're touching on how we work together in a partnership. When you're thinking about how partnerships should evolve to meet the new landscape that's a lot more complex, what do you think about how contracts and deal structure and even maybe the RFP process, what would you change within there? Maybe one thing?
Tying that to outcomes, right? And I think you need to pick the right outcomes. I don't think activities are the right, we said we'd call 5 people a day per FRM. I mean, it's great, they're doing their job, but we want to see outcomes. And how do we design the program to get those outcomes? And how do we do the contract And I think it should be risk reward. If you blow the number out of the water, there should be language that there's upside to the contract. There's always downside if you miss an SLA or something. But if you do a great job, I don't think companies would have any problem paying more because you blew the number out of the water. That's my 2 cents.
It really is the shared risk. It's the risk and reward that Brian has referenced. If we don't contract for shared risk, we don't contract for performance KPIs inside the contract, 100%, if I hit my numbers, I'm happy to pay more.
I love that, and I totally agree. Shared accountability, pay for performance, make it feel like they're a part of your organization.
Wait, it goes the other way too, right?
Don't pay for non-performance.
You shouldn't get a bonus if you're not delivering. So this is interesting. When you start thinking about applying innovation and tech into your programs, they're not all going to be successful. It's about test, learn, adopt, scale. So how would you rethink a partnership knowing that some of the things you do together are simply not going to work?
For me, I would go with the test, the learn, the kill, or the adopt and scale. And I'd be very deliberate about it, because when I say kill, I don't mean that the relationship is resolved and it's done. What I mean is, okay, you're a good partner, let's pivot someplace else. And we're doing that right now with you all too. I mean, from the general education on gen med space over to the Medicare space, it is truly a pivot. So the idea of killing it is not a bad thing. We have to fail super fast if we're going to be successful.
Brian, what do you think?
I think it's brutal honesty. If something's not working, we need to pivot fast. From a service provider, if something's not working, the dollars can be repurposed for something else. But it's always coming up, okay, we test, we tried, we either killed or we expanded. And I think you guys are partners in coming up with the ideas that we want to test. I don't think it's just like us saying, hey, we want to test this. I think you should come to the table and be ready to say, hey, we've seen this work. Please do this and we'll test it. And then if it works, full rollout. If it doesn't, we'll kill it fast. I think we need to be very nimble to be able to say that people stay on programs too long, don't do anything, and then a year later everybody gets in trouble or fired because they've been going along with it. So it's measuring impactful outcomes and then deciding on decision points after that.
So let's double click on that. We're testing, evolving, we're learning. Things are changing in the market we need to respond to. How do you take that lens and think about partnerships, if you should partner, what that partnership should look like so you can move with speed when necessary?
I don't want a partner that's just a vendor. I want a partner that actually is a thought partner. That does take a little bit of time, Kim, to build that trust. But once I get there, then I'm building synergies. Then I have a trusted partner that can whiteboard with me. So my easy example for this conversation is really that I have a problem, I throw it over to you, you start whiteboarding on it, you bring me back what you have, I don't like it, and then I start whiteboarding right back with you. And the next thing I know, we're on the board together, and now we're testing each other's intellect. And I think that's what a true partnership is. It's not just a vendor relationship.
I think looking at it from self-awareness or self-scouting, obviously you have experiences that we don't have, and looking at saying, okay, where are gaps? Where can we build? Where can we partner? And I think just being honest. I mean, partnership is not always the right solution, but a lot of times it is, and it's just being honest and looking at yourself in the mirror, your company in the mirror. Like, can we do this? Do we have the technology? Do we have the infrastructure? And if not, then find a partner that does all the things that Terry says. Like my board's like, that's the partner I want. But
it's a unicorn.
Yeah.
Okay, we're heading towards the final ending questions. But one piece of research I looked at in preparing for the conference was how often sales performance doesn't meet expectations for pharma. McKinsey has a report out there that shows 40 to 50% of new launches in established players aren't meeting expectations. Some of it's about speed, some of it's about planning. What is one thing you would change about the model or partnership process to change that?
I think it needs to be coordinated effort throughout the organization. I feel a lot of times you do your payer strategy, but you don't think of, okay, once this goes to the doctor, how is it going to play out in reality and how's the patient going to feel? And looking at the patient going up, because you're like, oh yeah, we have 80% of lives covered, but coverage is not access. And then how do you pull that through? I think that coordination of functional areas to really share that patient experience and plug in the gaps where they can to make it as seamless as possible, to shrink that 40 to 50% underperformance and make it a launch that in line with whoever expectation set it.
So design for market realities, not best case scenario.
Yes, I would agree. Yeah.
Just piggybacking off what you said, for me, it's like I'm going to reduce the whole perspective of reach and frequency. I'm going to drive for quality. I'm going to drive for feedback from the patient's offices in terms of the customer impact. And I'm going to lighten up on the reach and frequency because that's more of a traditional pharma measurement. I think if I make the customer feel more included, I think if the patient sees the results of what they're trying to accomplish, that's going to be more return on my buck anyways.
Okay. What is one belief you want to see pharma let go of as they start building a new framework for thinking about deploying these programs, partnerships? What is one thing we need to leave in the past? We'll go with Terry first.
All right, so I think that they need to stop the belief that sales teams are king. I think they need to be more integrated. They need to be more cross-functional. They need to pull on medical a little bit more, pull on reimbursement a little bit more. This universe that we have all grown up in is changing, and it is moving more from demand realization out in the field with sales to more of a critical thinking perspective on reimbursement and how we actually solve the problems of healthcare in the U.S.
Build for the battle, not for the organization. I think
that.
We don't have a static, tired model, have a flexible framework that can really delve into what problems you may face. You know, everybody has a plan until they get punched in the face. I think Mike Tyson said that. That's kind of the reality we're facing. You can have the best laid plans, but you need to be able to pivot quickly and move to the next thing to help fix whatever problem there may be. Orgs are great, but it's not the be-all, end-all.
Final question. Somebody asked me, since we're in Vegas, where am I placing my bets for the future? And I said, I'm placing my bets on being ready for change and having my teams be ready to pivot immediately. Where do you want to place your bets, Terry and Brian?
I agree with your bet, but I would also place my bet on reimbursement skills because of the complexity of the markets as well. What do you think, Brian?
Yeah, I agree with that. Medications are getting more complex, so the medical side is becoming more important. Because they're going to become more complex, the reimbursement's more challenging. So you need people to help pull it through. It's not just you write a script, you go to CVS and you get it. I think we've all experienced at some point in our lives where you're like, wait, it wasn't covered, I have to pay this much. I think that's a big challenge that the industry, they're addressing, but you're right, they're going to have to change. Things change all the time. They just have to be ready for whatever next comes at them.
Thank you both. I had an amazing time prepping for Asembia, doing the panel and jumping in the podcast. I want to leave the audience with the question, what are you doing to rethink your approach in this rapidly evolving market? And just a huge thank you to you both.
Thank you, Kim.
Thank you very much.
That's it for this episode of the Syneos Health Podcast, Conversations on Commercialization. Subscribe wherever you get your podcasts so you never miss an episode. If there's a topic you'd like us to explore, send us a message at podcast@syneoshealth.com. For more actionable, future-focused life science insights, visit the Insights Hub at syneoshealth.com.